Namaste. This educational surgical video demonstrates a very rare, previously unreported surgical flow diversion to a giant cavernous IC aneurysm associated with a very rare anomaly of having a persistent primitive terminal artery. This artery was supplying the complete posterior circulation and there was no contribution from the vertebral artery. So traditionally, we are taught three options for managing aneurysms. One is the direct surgical clipping of aneurysm, and now the endovascular treatment, and the other is cerebral bypass, where we either isolate or ligate or trap the with parent artery with the aneurysm. So this case is unique because the entire push circulation on both the sides was being supplied by the persistent primitive triangular artery, which was arising directly from the aneurysmal segment of ICA. This anomaly of having a triangular artery is quite rare. Overall prevalence is around 0.061% to 0.6% on the routine cerebral angiograms. This is a 25 plus minute surgical video, but I have divided it into four parts for your convenience. Part 1 covers the step-by-step demonstration of this index case, and the part 2 will discuss about the embryology and what exactly is persistent primitive triangular artery, and plus two more cases of such anomalous triangular artery aneurysms that we treated. And the third part will discuss in brief about the cavernous IC aneurysm management and what is giant aneurysms. And then we will go to the closing remarks where we'll make you realize that excellence has no postcode. To date, we have managed three such cases. Two cases required high flow bypass. Both are, to our knowledge, the first cases reported in world literature. One case having a basilar tip aneurysm with this anomalous artery was successfully managed with a direct surgical clipping without bypass. This particular case was a 55-year-old female with no known comorbid illness who presented to us with a chief complaint of left eye double vision and a partial drooping of the left eyelid of 1 week. On examination, her GCS was 15 by 15, left 6 cranial palsy was there, and a partial left third cranial palsy was seen. We got DSA and CT angiogram. You can see in the DSA here, there's ICA, there's a giant cavernous ICA aneurysm, and you can see the triangular artery exactly arising from the aneurysmal segment of the ICA here. So the triangular artery is supplying the whole post circulation. You can see hardly there is any contribution from the vertebral artery. So this is a triangular artery in the, and this is a hypoplastic vertebral artery filling only part of one side of the pica. So this is a right IC injection study was done to see the cross circulation. We could not appreciate much of the cross circulation across PCOM. So this is a CT angio. You can see both the vertebral arteries are hypoplastic and the complete post circulation is filling through the persistent primitive triangular artery. You can see here it is arising from the cavernous part of the aneurysm here, IC here. So the PCOM, you can see here the PCOM was not there. The PCA, one side was completely fetal and one side was filling from the primitive triangular artery. So this is, you can see the cavernous IC aneurysm, the giant one here, and that was the artery, that is persistent primitive artery. So here in this video, you can see that is a giant aneurysm in the cavernous sinus, and this is a ICA, and the aneurysm was projecting into the sphenoid sinus. You can see, and from the cavernous part through the petrous, this persistent primitive trigeminate is arising, which is supplying both the SCAs, PCA, ICA, PICA, and everything. So that is the triangular artery we can appreciate, and this is one of the 3D MRI angio. So managing aneurysms associated with these anomaly is extremely challenging, and we have to study the local vasculotomy in detail, like what we did, and this is how we made a diagram of it, and then understand and then look for the presence of thrombus or plaque and presence of cross location across ACOM and PCOM, and we need to study the neck vessels also. You can see they're quite tortuous, and we also need to evaluate the graft vessels that will be taking a radial artery or a saphenous vein. Once we carefully studied the cerebral angiogram, we understood exactly how blood was flowing and where the challenge was. The central question we faced was how do we treat this aneurysm without stopping the only blood supply to the brainstem. That is how can we treat this aneurysm just by not ligating the IC in the neck, because if you ligate the IC in the neck, the supply to the trigeminal artery will stop and the whole brainstem will suffer. The answer left was surgical fluid diversion. How do you cure an aneurysm? By applying a clip distal to it, not proximal, and by putting distal, the pressure increases and aneurysm rupture, and also without stopping a proximal flow. It was mandatory. So by placing, we performed a high flow bypass first, then we did a maneuver that may seem counterintuitive, but it effectively diverted the flow away from the aneurysm. Keeping in mind patient's condition, angiogram reports, and her family's financial situation, we discussed and offered surgical flow diversion as a best path forward. Endoscopy treatment has changed the way neurovascular surgery was being practiced in the last couple of decades, with its own great advantages and few disadvantages. Nowadays, cavernous IC aneurysms are best being managed by flow diversion, but not everyone affords, as neither even government health schemes support this. Here are the few different surgical options and strategies we consider for this case particularly. For aneurysm management, we had different contingency plannings. Option one was direct clipping, if possible, which is not possible. Option two was proximal ligation of ICA next to the origin of the persistent primitive trigeminal artery by exploring the cavernous ICA, the no man's land after the bypass, which was also less possibility we had. Option three was if proximal ICA ligation is the only option left, then expose the trigeminal artery and prepare for PPTA to intramaxillary bypass if needed. So that is a very rare possibility. And the last option, and which we are hoping, was a surgical flow diversion. This was our final strategy, placing a clip distal to aneurysm on the supracranial ICA, just proximal to the origin of the ophthalmic artery, with the high flow bypass in place, while maintaining the flow through the persistent primitive trigeminal artery, as will not be ligating the IC in the neck. Our preparation included lumbar CSF drainage for brain ligation because we're thinking of exploring the cavernous sinus, general anesthesia with full intraoperative neuromonitoring, including cranial monitoring and MEPSCP. We used FTO-JED approach with drilling of the clinoid to expose the proximal ICA. We also exposed the cervical ICA in the neck and prepared the left hand and the left leg for radial artery and saphenous vein graft. And if needed, we kept the internal maxillary artery also as a backup option for bypass if needed. Revascularization was our first and the most important step. We performed a high flow ECA to MCA bypass. In this case, we used saphenous vein. This secured a flow to the brain before we touched the aneurysm. And at the end, hemostasis was planned with the Surgiflow and fibrin glue for cavernous sinus. And as you see in the pre-op and post-op angiograms, we achieved exclusion of aneurysm with preservation of flow through the trigeminal artery and the complete post-aspiration. This case highlights one principle. In complex vascular neurosurgery, meticulous planning and revascularization first is the key to the safety. This patient was positioned supine, and these are the incision mark, the cranial incision, and then we used Doppler to mark the supratemporal artery. We harvest for an insurance bypass in case needed. So this is how we draped. The neck is exposed for the exposure of the common carotid artery and the ICA and ECA. And this is a coronary incision we marked to expose the frontotemporoorbitting zygotomy. So once the neck was exposed, you can see here the external carotid artery, and this is a ECA here. That is a ICA, and we put a tape around it, and we separate these vessels. So this is how we will mark the incision. We don't give adrenaline with the local anesthesia in this case that we use for routine cases, because we might inject into the STA and we might damage the harvesting vessel that graft is required for us. So we all know that STA has a serpentine course. So the branches arise in the outer edge. We coagulate it away, and we are dissecting in the loose area tissue here, and that is how we coagulate away from the vessel. And once the adequate length, around 8 centimeter of vessel is ready, that's a good flow, then we'll free it from the surrounding loose area tissue, and this STA is ready, and we preserve it till the end of the procedure. And this is how we marked our surgical steps on the wall of paper, And you have seen the angiogram images, and we used arterial line to monitor the BP continuously, beat to beat, and we used cranial monitoring and even the MEP, SSCP, because since this was supplying the trial artery was the sole supply to the brainstem, we need to monitor the MEPs and SSCP continuously. Then we went ahead with the FTO jet craniotomy. We did it just to expose the clinoid and expose the ICA proximal to the ophthalmic artery, which was not possible in this case. I will show you why. So then we did a extradural craniotomy. We can see in the picture that the clinoid is burying into the fundus of the aneurysm. So it is quite risky to drill here. We exposed. You can see under my clinoid is the fundus of the aneurysm, which is covered by a layer of dura. So we use rongers here, and once that is done, you can see under my tip of the suction is the aneurysm. So once the bone was completely finely drilled, we exposed partially the clinoid, and then we opened the brain. This is the Sylvian Fisher dissection. We need a wide exposure of silvification so that I can expose the bifurcation. We usually bypass with the inferior trunk of the MCA, and this is the left side. So then we have exposed the neck and the brain. We tunnel using an ICD. Then we have taken this saphenous vein graft. In this case, we have to be very much sure which is caudal and cranial because saphenous has a valves. So using that, we have tunneled the vessel from the neck to the brain, and this is a distal end, and this is a vessel of the inferior trunk of the MCA, left MCA. So this is how we are staining the graft end once the vessel is completely prepared and it is completely free from the adventitia. So we are taking out the vessels. We should not handle the intima. So once that is done, this is we do something called as a preloading, where we put heel and toe sutures. We don't handle the intima. You can see I'm touching the outer surface of the vessel. So once that is done, we put the distal clip first, then the proximal clip first. So the donor is ready with the preloaded sutures, two sutures already put, and this is how we do the arteriotomy. Then we do heel and toe end sutures first. I prefer intermittent sutures than continuous in brain, and in the neck we use a continuous sutures. So once we are using a 9-0 suture material here, the ethylon. So this is the toe end surgical knot we place. We take around 3 to 4 sutures. Then once that was done, two sutures just adjacent to the heel and toe, and then two sutures in between the line, and then we go ahead with the intermittent 4 to 5 sutures on each side of this midline suture because it is a large vessel, the saphenous vein. We took the saphenous vein because the radial artery was very small, and we didn't harvest that, and we went ahead with the regular is almost the equal to the size of the ST that we harvested. So for that reason, we harvested the saphenous in this case. So then we continued with the intermittent sutures. You can see almost all the sutures are being placed here. So after that, multiple sutures are placed to complete this one side of the sutures. In this, we have to be very sure that while taking these bites, we are not taking the opposite wall of the arteriotomy. Otherwise, the graft will fail because the stoma will get occluded. So then once the suturing is done, we look for any space where we can put the other sutures. So these last two sutures are quite important because this is a area of common leak. So uh, this is a common place where usually the anastomosis will leak. So there is some part of the dog ear here that we have to handle because there is a mismatch between the artery, donor artery and the recipient. So once that was done, the vessel is flipped. We do the cranial anastomosis first for this reason rather than the neck anastomosis because we can flip the vessel easily here, the real artery, because once we prepare the vessel for the proper size. So before releasing the clip, I have put a clip here because I don't want the blood to stay in the vessel and get thrombosed. Once we saw that there was small bleeding, so I have taken a couple of sutures before I finalize. I open the both the clips. So once this is done, we can the soma is perfectly functioning, small bleed, and this is the size of the artery that I told that we do the cranial anastomosis first, and so that we can mobilize the vessel very well in the brain. And this is the neck end of the anastomosis. So I'm taking out the adventitia over the external carotid artery here. It is quite important to identify the external carotid and the internal carotid. External carotid has the branches, so that is how it identifies, and ACA doesn't have any branches in the neck. So once that is done, so we have to study the pre-op angio. You can see that is a vessel originating, so we have to put 3 clips. So after that, since it's big, we used 11 number knife to do an arteriotomy. So we have to find out the equal size of the stoma and even the graft vessel size, the heel and toe sutures we have placed. So in this particular case, because in all the high flow bypasses in the neck, we use continuous sutures. So these are bigger vessels, the diameter is good. So that is the advantage of taking a continuous sutures here. So we take sutures from one end to the other end, then gradually we tighten the continuous sutures. And once that is completed, we flip it to the other side and complete the anastomosis completely. So these are the good vessels to bypass because the diameter is big. And even in this scenario, we can use 80 proline also here. So, so this is the opposite end that I'm using for anastomosis. So this is also continuous sutures from this side. So I have kept the suction beneath, you can see continuously, that sucks the blood, the saline that we irrigate. So this is a very high focus, almost 10x zoom here. So once that is done, we are placing intermediate sutures if I feel leak, and after that, you can see I have released the temporary. There is some bleeding, so we reinforced using sutures. Then after that, all the clips were taken out. You can see the bypass is feeling very well. So this is the neck that I have kept. So clips that I have removed, and this is the last clip that is removed over the bypass vessel. So it is pulsating very well. You can see the graft is filling and is perfusing the brain. So this is a graft. You can see in the neck there is a external carotid to the saphenous vein and the saphenous to the MCA. So the flow dynamics has to adjust once the bypass is done. And then we try to expose the cavernous ICA once the bypass was done. So this is the maneuver. We have released the CSF so that brain became lax, and I cleared this MCF base because I wanted to expose even the internal maxillary artery here. So between these nerves and the midmandibular artery. So that is the Meckel's cave. So this is an attempt to expose the ICA so that I can clip the ICA distal to the origin of the persistent tubular artery, so that the ICA in the neck supplies the tubular artery, and this cavernous aneurysm will not fill. So we know that this is a no man's land, it bleeds heavily, so a lot of cranial pulses can happen. So we discontinued this procedure, and we went ahead with the distal clipping, so that this is a distal clipping, you can see in the image, so that we'll expect to achieve the surgical flow diversion. So this is, you can see, this is a superficial ICA. I could not expose the ophthalmic artery. I'm putting this clip distal to the ophthalmic artery. The ophthalmic will receive the blood from the ICA, which is not ligated in the neck. So we are expecting that the ICA will supply the percentual artery, and you can see the aneurysm there. It is filling. So this is a post of CT angio. You can see here. So we have put only one clip distal to the aneurysm. This is the ECA and SV supinous vein graft. It is filling and it is perfusing the brain here. And there's a clip you can see in the supinal ICA, and the aneurysm has completely disappeared. This is an immediate post-op CT angio. The patient went to the CT angio directly from the operation theater. So the aneurysm has completely disappeared. The bypass is filling very well, and you can see the distal clip. There's no proximal ligation. Even the persistent primitive trigeminal artery is completely filling and perfusing the whole brain. And you can see in the picture that was there an aneurysm which has disappeared even after putting a distal clip. So this is a theory of surgical flow diversion, wherein the blood flow uh, will divert once there is no need of the flow further, and there is an availability of flow going to the other large artery. In this case is the trigeminal artery. So, and this is a post of DS. We can see that is the aneurysm which is completely operated. It was done after 10th day of surgery, and that is the MCA graft, which is not filling complete of the MCA, but some part of the MCA this graft is filling. There is a good flow from the ACOM, which was not seen in the pre-op DSA. We did a cross compression in the neck, and that is a graft which is seen here very well, and the aneurysm has completely obliterated, even though we have not trapped the aneurysm. It is just a distal clip, And they are expected that since the aneurysm is distally clipped, the flow completely diverts. You can see the cross ACOM flow in this case. So there's a good feeling of the opposite side using ACOM, and even the partly from the there's no PCOMs in this case, and partly from the graft here. So this is a case of surgical flow diversion. My understanding of surgical flow diversion comes from my early days in farming. It follows the Bernoulli's principle that we all know. In this case, the fluid always follows the path of least resistance. As you can see here, when the primary path is obstructed, it diverts. Like here, it diverts here. And if no path exists, it's find a path either safer or destructive by rupturing. So this video demonstrates that exact principle. You can see in picture. We have translated that into outcomes. In the last 11 years, in this village charitable hospital, we have clipped around 750 plus cerebral aneurysms and performed 160 plus cerebral bypasses, all done in the last 11 years at a village charitable hospital with a state-of-art infrastructure and an allied team and unwavering patient-centric values, proving that excellence has no postcode. We encountered three cases of persistent primitive trilateral pseudoaneurysms treated surgically. We'll first study overview of case and embryology. During embryologic development, forebrain circulation of ICA develops first and hindbrain is supplied by the primitive arteries. In a 6-week old human embryo, the primitive time artery develops as the largest of four transient connections between the primitive ICA and the paired longitudinal arteries that will become the basal artery. The other three are otic, hypoglossal, and pro-atlantal intersegmental arteries. At this stage, the trigeminal artery is the only main blood supply to the developing hindbrain. Normally, within 7 to 10 days, it regresses as the PCOM and vertebrobasilar system matures and take over the post circulation. When this regression fails, the vessel persists into adulthood. This is called persistent primitive trigeminal artery. Overall, the prevalence is 0.061% to 0.6% on routine cerebral angiograms, out of which the PPTA is the most common, accounting for around 80 to 85% of all the persistent keratico-basilar anastomosis. The PPTA arises from the posterior wall of the cavernous segment of ICA in about 85% of the cases. The remaining 15% it arises from the petrous segment. It typically runs in the cistern and inserts to the mid-basilar artery, usually between the ICA and the SCA. There are two classifications. One is modified Salzman classification based on post-circulation configuration. The other is ALAS based on relation to the abducens now. The PPTA is associated with several vascular conditions like these aneurysms, AVMs, and keratico-cavernous fistulas, Moema disease, neuralgia, large vessel occlusions. Surgical treatment of these conditions can be challenging due to complex anatomy and location. The key point here is understanding both the anatomical course and angiographic classification and angioanatomy of this anomaly is critical before planning treatment for any associated pathology. Studying and understanding this complex angioanatomy is a first key step for success in these cases. This is very important to define the surgical strategy and contingency planning in these cases. We encountered three cases. The first case is a patient with the SH with a tribal aneurysm arising from the tip of the aneurysm. The aneurysm was supplied with the persistent pulmonary artery arising from the left cavernous and petrous of the IC because the rest of the neck IC was atretic. On the right sided approach, both the PPTA and large PPCOM were encoded in the corridor to the aneurysm. The aneurysm was multiplicated with the ruptured dome. We performed posterior clerectomy for proximal control and achieved successful clipping. Post-op image shows complete obliteration, and this surgical video is available on our YouTube channel. The significance is that this is the first report case of such an anomaly. The second case is the routine case that we saw in this video. Third case is very interesting and highly complex case of ruptured fusiform persistent primitive trigeminal aneurysm with subclavian stele. This patient is a known case of chronic kidney disease currently admitted, and the detailed video is currently being compiled. MR and CT angiography revealed a large ruptured fusiform aneurysm of persistent primitive artery with a patent ACOM, PCOM, and well-developed arteries. A schematic diagram was prepared to better understand this unique circulation. The most striking finding on DSA was subclavian stele phenomenon occurring through the persistent primitive artery. Due to left subclavian atresia, the left upper limb was supplied by the cerebral blood supply across the PPTA. The blood from the left ICA was being stolen via the PPTA, the bilateral PCOM, and then to the visual artery, to the vertebral arteries, and then to the subclavian to supply the left upper limb. Bilateral IEC injections demonstrated filling of vertebral arteries via PPTA and PCOMs, confirming the state. The surgical management included exposure of the common carotid, subclavian and IC and IC application in the neck, and cranial exposure to expose the IC at the supraclavian part, and the basilar artery with the PPT aneurysm. You can see here in the tubo endoscopic tool that is a beautifully seen aneurysm and the basilar whole system here. We did a staged revascularization. The first we did common carotid to subclavian Dacron bypass to correct the steel, and then we did ECA to MCA high flow bypass for cerebral protection. Then we trapped the fusiform triangular artery aneurysm in the ligated the ICA in the neck, and then clipped the supraclavian ICA proximal to the ophthalmic artery and at the junction with the basilar artery. So the whole artery was trapped. All these three cases are highly complex with rare anomalies and unique angioarchitecture. To the best of our knowledge, such cases have not been previously reported in the world literature. The take home is these three cases are highlight the extreme variability and surgical complexity associated with aneurysms of like this. Neurosurgeons should be aware of the presence and significance of such variants when inputting imaging and planning interventions. Detailed understanding of embryology, classification, and hemodynamics is essential for safe and successful treatment.